Good evening, everyone. Welcome to our regular KSA weekly CMEs. My name is Dr. Teddy Wera. I would like to introduce our speaker today, Dr. Reuel Maina, who works at Machakos Level 5 Hospital. He's an ENT surgeon who did a fellowship in pediatric ENT at University of Cape Town and has a special interest in pediatric airway. So, Dr. Maina, karibu.
Thank you very much, Dr. Were. Thank you also the Kenya Society of Anesthesiology for inviting me to give this talk on endolaryngeal management of pediatric subglottic stenosis and the use of non-occlusive balloon dilator. I just want to share my experiences. I'm an ENT surgeon, as Dr. Were alluded to, and I did a fellowship in pediatric ENT, mostly focusing on the pediatric airway. It was a one-year fellowship at the University of Cape Town, and I was mainly focused at Red Cross Children's Hospital. Okay, so all the images that I'm going to project to you today are courtesy of the UCT and Red Cross Children's Hospital. As I alluded to, I have no disclosures, and I just want to share my experience with what we did, especially with the anesthesiology team back there. So I'll start with a case presentation. We had an 11-month-old girl who was a second twin who was involved in a shark fire burn and sustained injuries to the head, face, and hands. And so what happened was she was intubated at the scene, was brought to the pediatric intensive care unit, and stayed for 5 days before being extubated. And once on being extubated, was found to have a biphasic stridor, which wasn't resolving on nebulization, wasn't resolving on steroids, and despite being on an invasive ventilation, was still having respiratory distress. And so the decision was taken, therefore, because we thought it could be an intubation injury, to go to theater for a direct laryngotracheal bronchoscopy with possible endoscopic intervention. And so this is what we saw. As you can see, this is an image of the larynx with the supraglottis and the subglottis. And in the subglottic region, you can clearly see there is a subglottic stenosis. So what we decided to do is we decided to do balloon dilation. And the reason for this is because, first of all, this was an acute onset, and it was soft and membranous in appearance. And this is a child who has a otherwise normal airway and had no previous airway symptoms. So this is a very good candidate for balloon dilation. And there we used a non-occlusive balloon dilator. So we introduced the non-occlusive balloon dilator after we had made what we call a Mercedes-Benz incision onto the subglottic region. And it had a marker where you could actually, where you're supposed to put it at a certain level, and it is non-occlusive. So as you can see, it is like in a cylindrical fashion, and it can permit ventilation to go through as you're doing your balloon dilation. I'll come and explain how we did this and how we put the patient in theater later. But this is just a pictorial diagram of and a video of how we used to do it. And so this is the end result, as you can see, from a Cotton-Myers grade 3 to a Cotton-Myers grade 1 with adequate airway and with quite a good result. So we did 2 balloon dilations, each 2 minutes, and we did not require any rescue intubation. We didn't have to put an endotracheal tube. And the patient was transported back to the pediatric intensive care unit, where we put her on an invasive ventilation on high flow oxygen. We also put her on proton pump inhibitors, usually 1 milligram per kg per day. We also put her on a Silodex nebulization. This is a combination of ciprofloxacin and dexamethasone and normosaline in the ratio of 1:1:2, and also on steroids, dexamethasone. And so the child remained extubated in ICU and was weaned off the non-invasive ventilation 24 hours later. And follow-up review, the child remained asymptomatic. So the benefits of this non-occlusive balloon dilator is that it permits ventilation during dilation, as you could see. And also these children are vulnerable, especially the ones who have low respiratory reserve. So it's very suitable for those kind of children. And using an occlusive and a non-occlusive, the technique is the same, and the outcome is also equivalent, like the traditional occlusive balloon dilator. So we can discuss a bit of the endolaryngeal options for subglottic stenosis. And in view, this is the position that we use to put the children, also not only in subglottic stenosis, but also in other conditions like laryngomalacia, bilateral vocal cord palsy, tracheal stenosis, and all the other various conditions. So just in a summary, the difference between an pediatric, a child airway, and an adult airway. The most important one in our topic for today is, of course, the diameter. Of course, in a pediatric airway, you see it's only around 4 millimeters. That's in a neonate, compared to an adult airway, which is around 12 millimeters. And you can actually just see, according to Pusill's law, where he mentioned about resistance being inversely proportional to the fourth power of the radius, just a 2 millimeter reduction in radius causes a 75% resistance. And the resistance is increased 16-fold compared to an adult airway of the same distance, 2 millimeters. The cross-section just decreases by 30%, and the resistance is just twice. So just as the same change in diameter for a pediatric airway compared to an adult airway, the resistance in a child is much of more impact and of more significance. There are, of course, other differences that we know of in a pediatric airway. The larynx is usually a bit more anterior. It's usually more smaller. The tongue is relatively larger. And in a pediatric airway, you find the narrowest point is usually the subglottis, compared to the adults, where it's usually the vocal cords. And the epiglottis for the pediatric airway is usually a bit longer and narrower. So when it comes to pathophysiology of subglottic stenosis, of course, the endotracheal tube and the cuff, we can cause pressure necrosis, and this results in mucosal edema and ulceration. And that's what this causes. It exposes the cartilage, it interferes with the mucociliary flow. So it interferes with the ciliary flow, so it causes mucociliary disruption. This leads to infection and perichondritis, and also causes cartilaginous necrosis. So healing is usually by secondary intention, not by primary intention, basically because the subglottic region usually has loose mucosa, and it also has insufficient vascularization. So healing is usually by secondary intention. You form granulation tissue and fibrous tissue, and thus you get your subglottic stenosis and also the subglottic cysts. So we have congenital subglottic stenosis and acquired subglottic stenosis. For congenital, we have membranous. Membranous is usually a bit more mild and circumferential compared to the cartilaginous one, which has this characteristic lateral shelves, and elliptical in appearance. And once you see this characteristic lateral shelves in the subglottic region, it's a clear indication of congenital subglottic stenosis. And this, I think, you might experience even in the pediatric population. Sometimes it's the anesthesiology team which discovers this. You're going to intubate a child with using an appropriate endotracheal tube based on age and weight. You find it's not going through, and you have to use a smaller tube. At this point, sometimes it's diagnosed by the anesthesiology team. When it comes to acquired subglottic stenosis, just a brief history, there's McDonald and Stokes in the mid-1960s. They recommended that neonates to undergo long-term ventilation. They introduced that concept of long-term intubation for children who are undergoing mechanical ventilation. Of course, what this resulted is an increase in incidence of subglottic stenosis. And therefore, the techniques for repairing the subglottic stenosis were developed now in the next decade, in the 70s, by Cotton and his team. And that's when they introduced the concept of laryngotracheoplasties, and more so putting a cricoid, putting a rib cartilage as the performing a cricoid split by putting a rib cartilage to act as a splint and to expand the airway. So currently, because we know that prolonged intubation causes subglottic stenosis, there's a decreased prevalence. Of course, now with the advancements in neonatal high care, more options of non-invasive ventilation. And of course, now we know that when you're putting an endotracheal tube, it has to have at least a leak of around 20 to 25 centimeters of water, so that you don't put a bigger tube or a too small tube. So you don't put a bigger tube which can cause subglottic stenosis, which can be at a risk of subglottic stenosis. So intubation injury we have mentioned as a risk factor, meconium aspiration, and even burns. Also, gastroesophageal reflux disease is also a risk factor for subglottic stenosis. So currently the incidence for all the intubated neonates, you'll find probably around 1.9% to 2% will develop some element of subglottic stenosis. This is just an illustration. You can see this is a child who had been put for 10 days an endotracheal tube, had those tram track appearance of in the subglottic region. In this premature child, you can see the posterior glottic band. And then you can, as we go along, you can see the subglottic cysts. All these are intubation injuries. So when we evaluate in the clinic, we usually history and examination, of course, is very important. There's that perinatal inquiry. The preterm and the low birth weights usually are more risk of getting maybe you can think of a subglottic stenosis, and it could be as mirrored of also other congenital malformations that could be there. Then you should also, we also ask about airway specific symptoms, if there was a stridor during birth or at the period immediately after birth, any admissions for respiratory illness of croup. Mostly those ones who have had recurrent croup, mostly you find they usually tend to lie along that line of those ones who have congenital subglottic stenosis. History of intubation is very important, especially if you are to get the records of probably the size of tube that was used, how long the intubation was the stridor immediately after removing the tube, or was it gradual after the tube was removed? And also a history of feeding abnormalities of aspiration and reflux is also important. So normally, before we do any for the diagnostic evaluation in the clinic, the flexible nasoendoscopy was like a stethoscope to us. It was really important for us for all the patients to have flexible nasoendoscopy in the clinic or in an office setup. And this gives us valuable information. You know, it gives us the dynamic function of the larynx. You are ruling out because it's you are evaluating the nose, and the nasopharynx, the oropharynx, the hypopharynx, and the larynx. You are looking at the dynamic function. You're looking at vocal cord movement, and it was very valuable. It gives us a guide on what we are dealing with before we go and do a direct laryngotracheobronchoscopy. X-rays are important as well. This is just an X-ray illustrating viral laryngotracheobronchitis, what we know as croup. You can see the obvious stipple sign. With the flexible nasoendoscopy, you can also evaluate swallowing. You can do functional evaluation of swallowing as well to evaluate whether there is some element of reflux. But the gold standard was, of course, a direct laryngotracheobronchoscopy, suspension microscopy, and this suspension microlaryngoscopy. And at this time, we are evaluating the three levels of the larynx, that is the supraglottis, the glottis, and the subglottis. Because in this instance, we are talking about subglottic stenosis, we can grade the myocotton grading and also the trachea, all the way up to the carina. So this was the setup that we used for the direct laryngotracheobronchoscopy. Before even this setup, we would do like 2 or 3 checklists. We all should be ready. This is done in coordination with the anesthesiology. At some point, we would also evaluate, because we had a recording of the flexible nasoendoscopy, we would share with the rest of the team what we saw and what we expect. And we have to be ready with our instruments, same as the anesthesia, as they are ready, we are also ready with our instruments. And so what we would do is the checklist is read quite loud so that everybody is in sync. And we would first of all want to spray the vallecula using a local lignocaine spray. So we would recommend for TIVA, and we use lignocaine spray. I think the dosage was 9 milligrams per kg. So it was prepared by the anesthesia team. You can dilute it 1:1 with normal saline or 1:2. And we would spray the vallecula first, give the child back to the anesthesia team to bag and mask. And then once you are ready again, we put into suspension. Sometimes we would put into suspension directly after we have sprayed the vallecula before giving you back for bag and mask. But at some point, at some other instances, we just put directly into suspension. And once we put directly into suspension, I want to illustrate. This is the port for, this is the light source. One port is for the light source, and then this other port is where we would insert a 5.5 endotracheal tube for ventilation, and then we would go in with our scope. Now, when we are going in with our scope, we would railroad. For example, this is a neonate. We were using a 2.7 millimeter scope, and we will railroad either a 3 or a 3.5 ETT tube. 3.5 is when you can remove the knobby. 3.5 could fit with the knob inside the scope. And the this suspension has to be at least hand's breadth away from the chest, so that to permit for chest compressions in case you are doing some resuscitation. And all this, so we would have our tube to rescue in case we need. The anesthetists would also have their tube just in case. So our set has an endotracheal tube. The anesthetic tray also has his or her own endotracheal tube for rescue. All this is done in coordination, and it has to flow. And in case we need to put in a tube, we'd always put in a tube. And most of the time, this is the lignocaine dosage. It usually was 9 milligrams per kg. So let's say because one vial, 1 ml would have 10 mg. So probably if a 3 kg child, maximum dose would be 3 mL, and you could dilute that to 6 mL with normal saline. So in this scenario, we used to use this not only for subglottic stenosis, but for all the airway conditions that we had that we were doing an endoscopic evaluation, from laryngomalacia to circular cysts to bilateral vocal cord palsy to laryngeal webs, subglottic stenosis, subglottic cysts, subglottic hemangioma, tracheal stenosis. We would prefer not having the tube in for evaluation, but of course, if the child cannot tolerate, we would put the tube in. In subglottic stenosis, back to our discussion, we would grade it, grade 1 to grade 4. Grade 1 is up to 50%. Grade 2 is 51 to 70%. Grade 3 is 71 to 99%, and grade 4 was total obstruction. Sometimes you can also use the endotracheal tube to calculate the grade of the stenosis using this Cincinnati airway card. If you are using 0.5 centimeter less, 0.5 millimeter less, or 1 millimeter less, you can be able to equate it with, you compare the age and you equate it with the percentage of obstruction, and you can also use this to grade with your endotracheal tube. And of course, it has to permit at least 20 centimeters of water pressure. So management of this condition was mostly endoscopic, but it could also be open or combination or tracheostomy. But we try and avert a tracheostomy as much as we could. And all this depended on the patient factors, the age, the weight, the disease factors. Was it congenital? Was it acquired? And also the surgical skills of the facility or the center that we were working in. So endoscopic management, as I alluded to, was the primary treatment modality. And we wanted to avert tracheostomies in some of these patients. And also endoscopic management was an adjunct treatment when it comes to when you're preparing for an open airway reconstruction. And of course, advances are being made over the recent years. And so it keeps on improving. So in a grade 1 or grade 2, there is a higher chance of success compared to a grade 3 or grade 4 or multiple level stenosis, where you're more likely to require open reconstruction as well. So the good candidates for the balloon dilation were those ones who had a thin stenosis or a web-like or a soft stenosis, or if the scar was immature. But those patients who had a firm, mature scar tissue, or there was elements of cartilage narrowing or structural problems like the lateral shelves or missing cartilage, or a longer stenosis or multiple level airway lesions, they were poorer candidates for endoscopic balloon dilation. These are some of the studies that were done. Lang and Brzezinski in 2014 found there was no association between treatment success and age or gender or prematurity. And he also did around 2 dilations per patient. And the lower rate of success was observed in patients who had gastroesophageal reflux disease, or were small, less than 5 kgs, or had multiple level disease, or had a higher severity of the myocotton grade. Avellino also in 2015 found an overall success of 60%, and also he found higher success with an acute scar compared to a chronic mature scar. So this is what we call, this is an insufflator. It's called a Boston Scientific insufflator for insufflating the balloon. You see, this was the traditional occlusive balloon, and you had to time. Of course, you have to watch the saturations. It was a bit more hectic compared to the non-occlusive balloon dilator, which you can now permit ventilation as you're doing your dilation. This is an example of how we would do it. So you can see, as we are doing the balloon dilation, everyone is observing the anesthetic monitor. You're observing the oxygen saturations as it's going on. And how we determine the balloon size was upon the expected size of the normal airway. So let's say, for example, and we would use the outer diameter for an age-appropriate endotracheal tube. Let's say maybe a 3-year-old would require maybe a 4.5 endotracheal tube. So you know the outer diameter is around 5.8 there. So that's around 6 millimeters. So if the child has a subglottic stenosis, so you use +1. So you use a 7 millimeter balloon for the larynx. And if it's a tracheal stenosis, you add a 2 millimeter. You add 2 millimeters to that. So you use an 8 millimeter balloon. And this, we would also use the Cincinnati airway card for just to confirm as well. So when it came to endoscopic expansion procedures, it was selective patients, especially the ones who are younger, where balloon dilation alone was shown to be ineffective. And we still want to avert a tracheostomy. Also, those children who had recurrent admissions for previous intubations. And when you're doing an endoscopic expansion procedure, it's important to specify that you also need a good intensive care unit. And this one you would work hand in hand and in coordination, not only in the operative room and also post-operatively. So when you talk about expansion procedures, it was mostly an anterior cricoid split or a posterior cricoid split with costal cartilage interposition. This is just a demonstration of an anterior cricoid split using a sickle knife. So we would completely do the cricoid split endoscopically. There's an assistant who's filling the cricoid, and it has to give way completely. And then you do your balloon dilation. You do twice. And then after the anterior cricoid split and the balloon dilation, we would intubate with a half-size endotracheal tube, at least half-size larger than what could previously, half-size larger than of the recommended endotracheal tube. And we would prefer nasal intubation in this kind of scenario. We would do that, and we would keep the tube probably around 3 to 5 days in the intensive care unit. It acts like a stent, and it had also good results. But for the anterior cricoid split, would prefer in children who are, well, it's controversial. Some would say maximum age of 3 months to 6 months. Others would go up to 9 months. Posterior cricoid split, it's technically difficult. It's not as easy as it can look. So you have to harvest a costal cartilage graft and insert it endoscopically. So as you can see, this is a posterior glottic stenosis with subglottic cysts. So posterior cricoid split is done. You insert the cartilage. It's technically, it takes some time inserting it, even putting just that one suture, and it has also good results. And all this is to avoid also a tracheostomy. So we did a study in the hospital because the balloon that was being used now since 2019 as the standard now for endolaryngeal dilation in laryngotracheostenosis. It was discovered by Professor Lube, who's a rhinologist at the adult hospital, Grutoski. So it has been a game changer. It's safe and effective, especially in vulnerable children, but also it can be used in adults. So the aim of this study, it was a 30-month review, was to describe the technique and evaluate the outcome of this non-occlusive balloon dilator. We had 32 cases, a total of 29 children, all underwent the endolaryngeal dilation. 6 of them had tracheostomies. 7 had the simultaneous endoscopic expansion procedures. All were endoscopic anterior cricoid split, and 4 had to eventually undergo laryngotracheal reconstruction. So in the technique, oxygen saturation remained above 92% in all the cases, and no rescue intubation was necessary, and we did not abort. There was no aborting of any of those direct laryngotracheal bronchoscopy cases in any of those scenarios. So the outcome was 10 cases improved by at least 2 grades, 15 cases improved by 1, and in 3 cases there was no change. And in this one, there was no change. It was mostly framework. The ones who had they were not amenable to dilation, and these ones eventually underwent open reconstruction. So in summary, the non-occlusive balloon dilator is safe, effective, permits ventilation throughout the procedure, and it minimizes the risk and improves the safety in a high-risk population. So limitations, it was we didn't have a capnography. However, we tried towards the end of my fellowship, we tried to introduce the capnograph, as you can see in this yellow arrow. This is the light source as well. This is the port of ventilation we have put into suspension. So we tried to put a capnograph as we are dilating, as you can see, and from the yellow arrow, we put the capnograph there, and you can see we could be able to get a capnograph there. So in future cases, if there's any doubt, of course, we can be able to put the capnograph there. So those ones who underwent open airway reconstruction, and those ones now who had failed endoscopic treatment, those ones who had problems, ones now had to undergo open airway reconstruction. And in terms of open airway reconstruction, it can be either an expansion procedure, laryngotracheoplasty, which is the one which is more common and more popular. You do an anterior cricoid split or posterior cricoid split, or both anterior and posterior cricoid split and costal cartilage insertion. Or you can do a resection, especially in grade 4 Cotton Myers, where it's completely occluded. So you do a cricotracheal resection, and it can either be a single stage or double stage, but this could be a topic for another day. So in summary, every patient, it has to be an individualized plan. The symptoms, of course, and the disease factors are the ones which guide the selection. And when we are talking about the symptoms and the disease that we are talking about, it determines now whether you want to do endoscopic alone or you want to do it open reconstruction. And pre-op evaluation was crucial, where you have your chest X-rays and your flexible nasoendoscope that you have done. You evaluate your vocal cord mobility, feeding, or aspiration, and also gastroesophageal reflux disease. Patient factors, social and economic factors. Of course, we are in the third world setup, so you want to give the patient definitive management without, you want to avoid that tracheostomy. Tracheostomy has its own social factors that hinder them. We when they are going home with a tracheostomy, of course, it has its own disadvantages. And you also want to give them definitive surgery where possible. And also surgeon and institutional factors. Airway team, you need an airway team. The airway team comprised of now the ENT surgeon, the anesthesiologist, and also the intensivist. And you need also your correct instruments, appropriate consumables, and also good postoperative care. In fact, we used to say the surgeon would do half of what is required, and now the intensive care, the ICU, do the rest, then the next half, to be able to achieve full or good results. So in summary, even though we have talked about subglottic stenosis, it could be used putting into suspension and doing it without a tube. It could be also used for other diseases that were there, congenital and acquired. But that was just a brief summary. Thank you very much.
Thank you very much, Dr. Maina, for that presentation. I think at this juncture, I'd like to invite questions from the audience. Feel free to post your questions in your chat box, or you can raise your hand and ask your questions.
Yeah, thanks so much, Dr. Maina, for agreeing to be with us today. This is Dr. Chokwe. How much of this have you seen locally, and what procedures are you able to do with the equipment we have?
So I've seen Gertrude's Children's Hospital has DL equipment, which is appropriate. It's a Carl Stores equipment. I think we did one the other day, Laryngomalacia child. We did RI epiglotopexy. So, and Kenyatta National Hospital is in the process of acquiring them. So I don't know about the other hospitals, but I think because it's something that we want to start, like we want to start like a pediatric airway reconstructive unit. It's something that we start probably requesting hospitals to stock them. So far it's Gertrude's. And when it comes to the endoscopic balloon dilators, I came with some, but however, we are looking at how we can get one of the local distributors to have them. So, and then it can be used on a need basis. And then they are usually recyclable as well. One patient can use it for several procedures, for several dilations, even if it's repeated. So far it's Gertrude's, and KNH is in the process of getting them. And then for procedures, for the conditions that we can use them, we can be able to do, we have congenital conditions like laryngomalacia, bilateral vocal cord palsy, subglottic stenosis, laryngeal webs, also things like circular cysts, even for the trachea, congenital complete tracheal rings and tracheomalacia. All this can be evaluated using this system. In terms of acquired conditions, juvenile onset recurrent respiratory papillomas, although we prefer using a tube, we found most of them would still need the tube inside probably half a size smaller, a cuffed tube, so that we can be able to debride to remove the papillomas. But however, in some instances, we did not need to put in the tube. Also, in terms of some aspects of for the laryngotracheal bronchitis, and especially if they needed some dilation, we could be able to do in terms of acquired. So yeah, so there are various conditions that we can use using this system.
Thank you very much. I'm seeing there's some questions in the chat box. Dr. Ure is asking, what is the anesthesia technique used? I think it's what is the anesthesia technique used for these procedures?
I think it was, okay, I'm not so good in the anesthesia, but it was a total intravenous anesthesia. I don't know if that's the question. And then I think they used to use sevoflurane. And yeah, I think in terms of anesthetic technique, maybe that's what I can say, unless there's something I'm missing.
So thank you, Dr. Ure. I think, are you satisfied with the response?
I think from the previous presentation that we had with Dr. Maina, part of this thing is apneic ventilation, really, and I think some of those catheters have a passageway for which you can have jet ventilation occurring as they do their balloon repairs on some of these children. So TIVA on the side to maintain the anesthetic space, and as they're doing their balloon dilatation, you have insufflation techniques that they use on the side to make sure the child remains fairly well oxygenated. Let's see.
Thank you very much. So the next question is by Simiu, who asks, how will we safely suspend the child in our setup?
So we would need to get this suspension tray. We could just, it can be made even by the technicians in the biomedical department, but also Carl stores have a suspension tray that they usually have in their equipment, and it's just a matter of ordering, that's all. And then it's just fixed on this stand which is available, this clamp which is available. So in terms of availability, we can just get the biomed people or the Carl stores or any other company to get it for us. It's easy to get, but it can be made by the biomedical people in the hospital.
Thank you.
But we can also modify even the normal Miles tray. We can modify as well if it's available.
Thank you, Dr. Ari. So the next question is by Nancy, who thanks you for the presentation and is asking whether this can also work for congenital laryngomalacia.
Yes, yeah. In fact, laryngomalacia is 60% of the congenital airway conditions is laryngomalacia, and it's the one we use, so it can work for laryngomalacia definitely. The one we did in Gertrude's had short RI epiglottic folds, which we did RI epiglottopexy. I think it was with Dr. Mwendwa. Yeah, so it's the best to use actually.
Next question is by Brenda Miogo, who was asking whether the balloon can be reusable for multiple patients.
Yes, it can, especially in our setup. However, where I was at Red Cross, they were easily available, but because I even carried the ones which patients had used, so it can be cleaned and reused in another patient. But it works like 4 and 5 times before it gets spoiled or non-usable again.
Next question is by Simiu. Risk of laryngospasm during the procedure.
So we reduced that with the LIGNOCAINE spray. And thank you, Dr. Simiu, for that question. In fact, I forgot to mention, we used to spray the vallecular and also the vocal cords. So once we spray that, it reduces the risk of laryngospasm significantly.
Any further questions, comments, clarifications? Okay, there being no further questions, I'd like to thank Dr. Maina. Thank you for making time to come and give us this presentation. It was quite an illuminating presentation filled with lots of pictures and videos, which I think we've all enjoyed. We hope that next time we can partner another time for another presentation that touches on both ENT and anesthesia. Maybe in terms of announcements, just a reminder about our conference coming in August, that there's still early bird slots for registration, and also to remind members to renew their annual subscriptions. The next CME is going to be communicated in due course. Thank you very much to those who've logged in, who've asked questions. And I think at this point, I would like to draw the meeting to a close and people can leave at their pleasure. Thank you very much and have a nice evening, everyone.